Remind me, I don't think I showed this last week, and now I can't remember though. This was of the this. Do you remember this?
I remember one with air in it. I can't remember whose it was.
Okay, maybe I did show this. It was
Was it
an
a delayed
atrial
inflation?
fistula.
Yeah, we saw
Yeah,
this.
it was post inflation. Okay. Well, I'm going to skip that then. Obviously, I've shown. I know I've shown one of these before. And at UCSF, we were doing a for every missing or retained surgical instrument, we were doing pilot radiographs or specimen radiographs of whatever was missing. And this is a patient at Duke. We've started doing the same thing. This is the pre-op image. You can see she's got a big hiatal hernia. And this is the post-op image. Now you can see there's closure of the sternum already, but during the final needle count, they were off. And you can see they've done a mitral valve replacement. And, you know, here you could see the three little circles of the typical mitral valve prosthesis. And then, you know, one of my colleagues noticed this, and it's interesting, right? Because it looks like it connects one of the little circles to the other. Fortunately, though, we did a specimen radiograph, and so we've started doing this, like I said, if they know what it is. And they weren't sure if it was a 2.0 or a 4.0 needle that was missing, but you know, having these side by side, and these are just placed in the patient's jacket, you could do measurement, say it's about 17 millimeters, and sure enough, you know, it's close, 16, something in that neighborhood, you know. So we thought that was probably going to be a missing needle. We did obliques, and you'll see here that on the obliques, sure enough, when I window it, you can see this now moves off of the valve, and it's posterior to the mitral valve on both of these oblique images, based on where it is moving. And so, you know, I think this would be easy to overlook on the original image if you don't have the specimen radiograph. And sure enough, they went in, found the needle, took it out, of course had to open up the patient again, but needle no longer there. So is anybody else doing these? Because there is actually one paper that's been published on experience with these, and at least anecdotally, it helps improve our confidence to know what we are looking for. And it's not that hard to do. It takes the technologist less than a minute.
Not routinely, but usually our problem is the overcount, not the undercount.
Yeah. So, but this was this is the first positive we've had. I mean, fortunately, yeah, these are rare events, but
tough case.
Yeah. Yeah. And this all came about, there was a non-metallic clamp that had been missing and ended up left behind years ago. And it was one of those ones, they did a radiograph, and the only thing on there was a metal spring, which nobody was sure if it was in the patient or not, but the rest of the clamp was plastic. And so if they had done a radiograph of what was missing, then it would have helped to figure that out. This one is an interesting radiograph. Now we've seen, I think if you do enough TAVRs, people have seen embolized valves. And looking at this one, this is the valve in the expected location. This is the core valve in the unexpected location within the ascending aorta. I think you can see some aortic valve calcium here as well. The thing about this one that was more complicated, because I know I've shown one case where it just ended up embolizing into the aortic arch and it stays there, no big deal. This one they noticed right after the valve embolized that it created a dissection and injured the wall of the ascending aorta. So this was the subsequent CT that was done, and then the patient was transferred for further evaluation. And so you can see the dissection flap, and it really is limited to the distal ascending aorta and then the arch. And in fact, at surgery, they found the entry tear basically right next to the prongs of the valve. And then you can see the other valve in the appropriate location across the aortic valve. And so they did end up doing a sternotomy, took out both valves. The patient had a heavily calcified bicuspid valve. So they put in a bioprosthetic valve in replacement of that. And then they've also done an ascending and a hemiarch replacement of the aorta. So, and I know I recently showed a dissection complicating the placement of the TAVR just with the catheter, but not one where there was related to that abdominal aortic aneurysm rupture and dissection, but this was one, it looks like, from the valve embolizing itself. And I don't know if you've seen this experience too, and one of my colleagues, Lynn Kowick, and I were talking about this yesterday, that in her experience, and in this case, the bicuspid valves tend to be at higher risk of embolization. I haven't actually looked up to see if that's true in the literature or not, and I don't remember what the other one was, but this was a heavily calcified bicuspid valve, so it fits with that. And then this one, Seth on here yet?
I don't see him this today. Okay.
Well, this one just came up, and one of my colleagues saved this for me because this is a phenomenal case that this is now the fourth example I have of this, and this is a recent one that Seth had shown. So this is a patient who is post lung transplant for cystic fibrosis. They're still only 30 years old, so they're fairly young. And this was a PE study that was done. And immediately you can see there's some bizarre contrast enhancement. And fortunately, this was actually, the bolus was kind of missed in this case, but it actually worked out to our advantage because you can see there's less contrast in the PA at this point, but we have systemic contrast, and you can see these huge transpleural systemic to pulmonary artery shunts, much like was shown in prior cases, the one that Seth showed, and then I pulled up the other two I had. This is post-transplant, and I don't know why this patient developed these, but you can see them bilaterally. You can see all of this essentially white smoke in here from positive or inflow of opacified systemic blood. Look how big the right internal mammary artery is, and you can follow it actually to one of these collaterals, huge collateral right here in the right middle lobe. And this is not an AVM, this is all arterial going back to the pulmonary arteries. They were able, while the patient was still on the scanner, repeat and did an earlier phase, like a pulmonary artery phase. And so in this case, you see, not surprisingly, that we now have smoke like we've seen in the other ones, because you are earlier and you have the left to right flow of blood from systemic artery to pulmonary artery here. So this one is quite impressive. This patient's had several CTs, and this was, I have their pre-op CT, but this was a few years ago. This was 2015. This is fairly immediately post-transplant, and they don't have any of that, not surprisingly. Yeah, I don't know what exactly this area is. It kind of looks like a little infarct, and I don't know if it was some sort of insult that predisposed to formation of one of these. The patient didn't have emboli at this time. I don't know if this was just related to the harvesting of the organs, but then they periodically would get CTs. And in this case, this was correctly called equivocal, or said it was suspected to be a shunt and not a PE. But as we've discussed in some of these other ones that I've shown before, don't do a VQ scan in these cases, as was done here, because all it does is give you the same thing, because of course you have shunts, so this is systemic blood coming into these regions, and then of course this taken in isolation looks more like a high probability VQ scan for PE, even though it's not, that these are all flow artifacts from shunts. So I think that's now, between Seth and I, the fifth one of these systemic to PA collateral cases that we've seen, and all in different circumstances.
That's impressive. Yeah, I can't figure why that it would occur. I mean, have they all been in all different reasons for transplants, or just CF patients?
No, well, the other ones weren't in transplant patients. Oh. The other ones were here. I'm going to show one more case. I just stopped so I can change this here. The other, like, one of them was post-trauma. The other two of them were post-infection, presumably. So I don't know.
Well, the only reason I asked for that one with the CF, I mean, they probably have bronchial artery hypertrophy pre-transplant. I wonder if there's just those humors floating around already. just from
Yeah,
the
I mean, I've never seen it this significant post-transplant, though.
right.
I think that's a really good thought, and I don't know. Yeah, unless there was some other ischemic insult or something that recruited the systemic vessels. I don't know.
Below, it's just like that little thing is through the side. It's just really
Somebody,
right side.
Okay.
is that somebody talking? I can't.
Yeah, I think it was
Couldn't hear that. Okay. All right, and then this is the last I'll show. This one's pretty interesting. You can see on the radiograph, there's an abnormal opacity over the PA. You've got a little bit of a hilum overlay sign here. On the lateral view, it is anterior, as you can see right here. Now, I will go to the, I'll go to this CT first. And you can see this patient does have a goiter, as you can see here. They've never had surgery, which is the interesting part, because they have this thing in the anterior mediastinum. And honestly, if I just had this, and in fact, when I just looked at this, in a 60-something-year-old patient, I think this looks reasonable for a thymic neoplasm. You've got some heterogeneous enhancement, calcification. Obviously, when we talk, I'm not a huge fan of the 4Ts, just because thyroid in the anterior mediastinum is so unusual unless you can clearly connect it up to the thyroid. It does happen, but this one, I don't see any sort of communication. Here you can see that goiter, and maybe there's just an inferior thyroid vein going into this, but I would have thought that's a thymic vein. But anyway, this patient underwent biopsy at an outside hospital, and you can see, I think probably you could have argued stopping the biopsy right here when you see that there's the higher attenuation and all of this iodine in it. I've never seen a thymoma that was that dense. And so they got, the interesting thing was, like, reading through the path, they got thyroid tissue, and then the pathologist apparently diffed it as either ectopic thyroid goiter or thyroid within a mature teratoma, which, there's no fat in that thing. And then they ended up undergoing a, thyroid nuke study, and this all had uptake here in the anterior mediastinum. But then, of course, on the iodine scan, the nukes people basically just copied the pathology report and said could be ectopic thyroid or could be a thyroid goiter or thyroid tissue within a teratoma, which is entirely unhelpful. I mean, this is just goiter. It just happens to not connect, and it's been stable for several years now. But this is the first one that I remember that I can't really clearly connect the dots with the neck. But Jeff, do you agree? Like, at least on the post-con alone, that kind of looks thymic-ish?
I agree, absolutely.
So,
yeah, the thyroid is usually pretty straightforward. It's, like you said, it's denser, easy to do an iodine scan if there's any.
Right.
We get about one where those a year sent here as mediastinal masses. That's just thyroid.
Yep. Yeah, and this is one of those ones where non-con would have been helpful originally. Instead, I guess they did a contrast CT, but that was all elsewhere, and I'm not sure where. So, all right, I will stop there.
All right, thanks. Peter, you want to go?
Sure. I have two quick ones. Mine are pretty quick. First one is just very quick. It's just a nice case for trainees. We'll start with the radiograph. So heart is on the right side, so dextrocardia, right arch. Not much else to see here besides that, but you can see the CT. So combination of situs inversus and lots of mucus in the airways. So this is a confirmed Cartagener's case, Cartagener syndrome. Patient also has, I didn't include it, but they have extensive sinus disease, persistent middle ear infections since childhood, and hearing loss.
Nice case. Was there a family history too? Do you know?
I don't remember if there was a family history,
okay.
But yeah, but that would be common. Okay, and then this one is one I read the other day. I read with the first-year resident for pulmonary embolism, and it's a good PE study, so no pulmonary embolism. That's correct. But there's something more sinister going on here than just a negative PE study. So one thing that immediately catches my eye is this aortomitral intervalvular contour here looks abnormal. Then as you come up, I mean, you see something that looks like a mass right here. So this patient has, if you look, he has a aortic valve replacement, and you kind of lose the contour here of the medial aspect of the root. So immediately I saw this, and I'm worried. So I looked at the echo. The Thoracic Echo was just very non-specific. They said that there was basically diastolic flow into the LVOT, which would mean regurgitation into the LVOT. So obviously that increased my suspicion for a big pseudoaneurysm here, and recommended a cardiac or gated chest CTA, which was done later in the evening. And here it is.
That's a great call, Peter.
So a big pseudoaneurysm here of the intervalvular fibrosa.
Wow.
With some clot. So this is clot here, and then you can see clot along. This is also clot right there. But just
yeah, that's a
but just kind of a tricky.
Really good one, Peter. And it's like,
that's a grand slam home run.
Yeah. So this would be
just an interesting point of discussion. So we have been doing RCT pulmonary angiograms with sort of dual phase scanning for about 10 years, where we time off the left atrium, not the pulmonary artery. And you know, it's in our licensed GE protocol. And when we first released those, a lot of people, you know, some of the end users, which I don't know where they were, complained about it because they thought it was unusual. But we pick up aortic dissections, we pick up a lot of cardiac pathology, and we've done that ever since. I don't. Do you guys ever do that? Did this one just happen to be really early pulmonary arterial phase, or is this how you do your PE studies?
No, we this one happens to be like that just because he's an acute. I mean, usually on most of our PE studies, we get a lot more contrast on the left side.
Okay. Mm-hmm.
This guy is in severe. I mean, he presented with 1 week of heart failure, and the reason is because of the severe regurgitation. So you can see all this edema that. So this guy's in severe heart failure. So I think regardless of the time, the LV function is so poor that the basically the bolus is so compacted.
Yeah, you're not going to get it through.
Yeah, so whatever kind of protocol you use, I think it would just get thrown off and.
Makes sense.
But yeah, you should, because we see a lot more contrast on the left side typically.
What do you guys do, Travis?
We are. I'm trying to get us to move towards that. When I was at UC, we had changed to a left atrial timing. We just do a longer scan delay right now. It's still off the PA, but yeah, occasionally we still run into this issue, and it always scares me.
Do you guys have the same issue with people with pretty bad heart failure? You get this kind of scan, which is actually pretty good for the pulmonary side, right?
We don't.
Yeah, exactly. It's yeah.
Yeah, I mean, if it's really poor LV function, I guess you can wait all day long, because we wait. What we do is it triggers at 60 Hounsfield unit increase of whatever blood pool is. And
Mm-hmm.
when they have really poor LV function, the ROI, if you look at the graph, it often just sort of dances around. I think eventually the techs get nervous and just push the button, rightly so. But
Mm-hmm.
you can tell a lot from those injection profiles, especially in a case like this. You'd probably see a lot of wobble on the timing, as opposed to the nice quick uptake as the contrast bolus is coming in.
Mm-hmm.
Yeah, that's a fantastic case, and that is a spectacular call on that.
All right, well, that's all I got, guys.
Thanks for sharing.
Thanks, Jeff.
All right, I got 3 quick ones here. I wish David were here. He'd like these, but he'll get them in the email. So this is a young woman who presented with fever, dry cough, and chest pain. I think she was otherwise healthy. And you can see she's got fullness here to right hilum and some ill-defined stuff in the right lower lung. Here's the lateral, and you can see there's a little bit of filling in that infrahilar window. The posterior wall of the bronchus intermedius is a little bit thick. So it looks like some lymphadenopathy and something going on in the lungs. That is unilateral. So not a good look for sarcoid. I could always consider it, but it wouldn't be one high on my list. But when I see this, I would think about I think about infection, particularly endemic fungus like histo. There's some other weird infections that you might think about, not tularemia like David's shown, but that would be in there, Q fever, anthrax, and then of course a weird lymphoproliferative disorder, but with that history, it sounds more acute. So because she had chest pain, of course, she got a PE study, and you can see this nice lymphadenopathy in the subcarinal space and the right hilum. There's some smaller left hilar lymph nodes. And then in her lungs, you can see there's this more confluent area around there, and there's some surrounding ground glass opacity, and then you've got that dominant nodule right down there, and that's about all there is. So, I mean, to me, this looks like pretty much, I would really wonder about fungal infection, but it's not the most classic appearance of histo because I don't see the little satellites, and I'd wonder if she hemorrhaged a little bit or if that's just some endeminous lung. But anyway, they ended up doing a bronch, and they actually got the bug in the transbronchial biopsies of the lymph nodes. Cultures rarely show anything. The urinary antigen would be positive, but this is a case of acute symptomatic histoplasmosis with lymphadenitis. And so it's thought that the chest pain is caused by the inflammation of these lymph nodes in these patients. Now, she got treated. I'm not sure why, because a lot of times these are self-limited, but just for a short while, and resolved. So that's acute histoplasmosis. This is another case. So this patient had a kidney transplant several years ago and came in with fever and cough, and you can see all this dense consolidation. And there's it does in the lateral view, nice, mostly in the upper lobe there. Because she's immunosuppressed, they do CT. I still don't understand why all the time. But what it shows is sort of a mass-like area of consolidation, but there's some cavitation in it. And then there's all these adjacent nodules. It is lobar, and there's not really much, there's like a tiny little effusion, and there's some nodules down here. So not your typical bacteria pneumonia, unless you think of like pneumococcus, which often has effusion. She does have some lymph node enlargement as well, but not to be unexpected there. I would have wondered about blastomycosis, given where we are, but elsewhere you could think about some other unusual organisms. Of course, with the cavitation, you might think about staph or strep anginosis, but usually they incite a lot more pleural response. So she got bronched, and this grew out nocardia, which that used to be the Astroides complex, a nocardia species. Let's see, I have it written down somewhere. But anyway, this is a nocardia presenting as rather extensive lobar consolidation with cavitation. And so, yeah, it does all sorts of crazy things. But to me, it's always been a mimic. Nocardia has been a mimic of, and blastomycosis are these mimics of other infections that tend not to get pleural involvement nearly as much and have a propensity to cavitate. And then this last case is a good teaching point for residents. So one of the things I always, when we do a routine chest CT, we typically scan with the arms up. And anytime you see the arms down, you should always ask why. And depending on your electronic health record and risks, we have a field for tech notes. And I've always encouraged our technologists to leave a note for us why they did something differently, or if it's a limited study. And they'll usually put a note like the patient couldn't lift their arm. But it can be a clue to something going on. So like in traumas, if one arm's up and one's down, I've seen scapular or clavicular fractures. I've seen giant metastases taking out of the humerus or the scapula. I've seen all sorts of pathology. But this is one I've not seen before. This patient is a lung transplant recipient. And you'll see the humeral head here. has got subchondral collapse, so a nice avascular necrosis, and they happen to have it on both sides. And this was a new finding. The previous scan, arms were up, and the patient had no known AVM. So this is a long-term complication of the heavy immune suppression and some of the drugs they're on. So just the reminder, anytime you see arms down on CT, always check. And most often it's just bad arthritis or rotator cuff tears, but it can be a clue to the pathology. And this was really the only exciting finding on this patient, but that's nice subchondral collapse of AVM. All right, and that is all I have. So I guess we will end early today. Hopefully David will be back next week, but thanks for the great cases, guys, and I'll talk to you later.
Take care, guys.